privatisation of the industry. And Anne says, I would call in, but I'm too angry. As a retired nurse, we have known literally for years the issues of aged care. And when will it ever change? Privatisation of the sector, casualisation of the workforce. It all comes back to not enough registered nurses and trying to run it as a business and not a health facility. Frustrating beyond words. Well, I have a feeling Professor Joe Ibrahim is going to echo something of what you've just heard there. He's the head of the Health Law and Ageing Research Unit at the Department of Forensic Medicine at Monash University. Joe Ibrahim, good morning. Good to talk to you again.
Thank you, Virginia. I'm pleased to be here.
What has gone wrong here in the aged care setting?
Well, so much has gone wrong, it's difficult to summarise in a sentence. The fundamentals are the aged care sector was never prepared and hasn't been prepared for over 20 years to manage any crisis. The Royal Commission has proven that with their interim report in November last year. And we've had 20 reports showing major failures in aged care, including shortages of staff not having the skill sets that they need, the free market principles where there's a lack of transparency, a lack of information given to the residents and their families. There's a lack of accountability of where our $20 billion of taxpayer money goes every year. The providers aren't required to account for that. We know that there are profits being made in aged care and homes are not compliant. We know that the regulator has failed and the government's own inquiry demonstrated failures in regulation. All of the issues with this pandemic and this outbreak was foreseeable. We knew in March the crises that had occurred in France, Italy, Spain, the UK, Canada, US. We knew the mortality rate was high in older people in February. We knew there were gaps in infection control. In the years leading up to it, the Aged Care Quality Commission has data and they audit the homes and they have a database which tells them which homes have problems with shortages of staff, which homes have infection control problems. We know the homes require communal living. There are shared bathrooms, there are shared rooms, there are shared dining areas. You know that the personal care workers have to be helping hands-on the residents. And so the issue of physical distancing was never possible. The issue about having well-trained infection control was never there. And so it's no surprise that it's occurred. What is surprising is how little we as taxpayers and as a community have called to account all of our leaders on this matter and that we haven't had a debate, an open and honest debate about what we should be doing.
What a litany of problems you've just listed there, Joe.
Well, that's really just half of them. I could go on, but people tend to not be interested and really want a simple solution to a really complex problem.
Well, we might get to solutions later on, but really we're just dealing with emergency management here. Daniel Andrews says he wouldn't have his mother in some of these private settings. Would you have yours?
My mum wouldn't leave home no matter what. I'd be really concerned about where I would choose. I think Daniel Andrews has got the evidence from the reports from the Royal Commission, from the ABC profiles, from families that have talked about it. Yeah, they're personal decisions, but I can understand why he would lack confidence in some facilities.
And yet, we had an outbreak in Newmarch and also I think in my other home in New South Wales. You'll remember the name of it, Joseph.
So that was Dorothy Henderson.
Dorothy Henderson. So you had those outbreaks there and then relatively quickly contained, but not before tragedy. The reason we've got such big outbreaks here in Victoria only, though, is that something to do with the system, the aged care system here, or is it to do with the fact that you've just got an outbreak of the virus again?
Well, I think there's 2 points to make. We do not have the lessons learned from Dorothy Henderson Lodge or from Newmarch. There's been no public disclosure of what happened and how that was managed. So that's a really important point. The second thing is if you look back to the envelope modelling, and I raised this earlier, when we had Dorothy Henderson and Newmarch outbreak, we had 23 homes that had an infection back in April. And so that was almost 1%, and the government was pleased saying it was so low, but the community transmission rate was extraordinarily lower. And so the chances of an outbreak occurring in a care home is probably 10 times greater. And so any community transmission increases the chances of this occurring in a home. I think the other point, Virginia, to make is a care home or a nursing home has up to 80 residents, would have a minimum of 80 staff per day going through there, would have another 80 visitors, and goodness knows how many others. And so it's not like it's a single room with one visitor. It'd be a bit like walking through Chadstone in how you need to think about it. Right. So it was always a very high risk.
It was always known, wasn't it? I mean, you mentioned all the overseas examples, but even before that, this was a setting that was always known to be particularly at risk. Given that, and I was pressing Alison McMillan on this firmly before, the Chief Nursing and Midwifery Officer for the federal government, about why there wasn't a specific plan for pandemic preparedness and management in the aged care settings. Do you know why?
No, I've got no idea, and I think these are questions that now need to go back to Brendan Murphy and the group that set up the pandemic response back in February.
So you're clear that this would be a federal government management strategy, not one that's incumbent on the states?
Well, the preparation, I believe, firmly sits with the federal government, who are responsible for aged care. It's our taxes, it's our $20 billion that goes into aged care. They have oversight of it. It needed national coordination with centres in each state to be doing that. We did that for public health. We didn't do it for aged care. We're doing it now for mental health. We're still not doing it for aged care. If children were involved, we would be doing it for paediatrics, and we'd be getting paediatric specialists involved to do this. We're not doing it for aged care, and we're not doing it because the residents that are directly affected have no voice, and the people that are meant to be advocating for them are currently silent.
Why are the people meant to be advocating for them silent? And who do you mean when you say that?
Well, I think organisations such as COTA and OPAN, so they're two groups that ought to be speaking up.
Yes.
And speaking very clearly on behalf of residents and their family.
And why don't they?
Well, those questions would need to go to them.
But there is an issue here, isn't there, about most of these groups receive federal government funding. Look, as a sceptical journalist, I'd conclude that when you're receiving federal government funding for your organisation, you might be a little hesitant about criticising the government. Is that a fair surmise?
Well, I think that's a fair statement. I'd encourage everyone to go have a look at the websites and have a look at the annual reports of these groups and see how much money is being that they get from the federal government, and people can make up their own mind about whether that does or doesn't influence behaviour.
And what about the difference between the private and the public system that you have, particularly here in Victoria? We don't have many, I'm touching wood when I say this, we don't have many infections in the state-owned and operated aged care settings, but you do in the private. Can you draw conclusions from that?
Well, I think that there's a natural experiment that we should learn from. There are approximately 200 public sector homes, and there's approximately 750 homes in Victoria. So what we should be doing is comparing what's happening in the public versus the private. A lot of the public homes are in regional areas where the private providers will not go.
Right.
And the public also tend to look after the more complex residents, particularly those that are bariatric or got significant brain injuries. And so that the public sector tends to get the much more complex. The differences that we know are that there are differences in staffing levels and ratios and staff skill sets. We know there are differences in location. I'd be fascinated to better understand it because a lot of the building stock in the public sector is older. So I would have expected more transmission there because they're more likely to have shared rooms and shared bathrooms, whereas the privates tend to have far more single rooms and en suites. And so in a sense, it doesn't make sense looking at just the structure why those outbreaks would be greater in private. It makes sense when you look at the staffing and the staffing qualification.
Well, that's really interesting. I was talking about staffing and about how the workforce is managed in aged care with Alison McMillan, and talking about those now rather, I guess, unpinned and vague strategic actions that the federal government wanted to take with the workforce there as part of its review of Australia's aged care workforce. It's their strategy. I don't know if any of this has been put in place. They're all very nicely stated about how you manage that workforce. But I must say, a key issue that was not identified and called out as a problem is the casualisation and transient nature of the workforce. I conclude from that, Joseph Ibrahim, that the federal government doesn't have a problem with that?
Well, I assume that the multiple federal governments, so not just this one, multiple federal governments have persisted with a free market model, which then said, here's the money, provide the care, and the resident will tell you whether they're happy or not happy based on their ability to stay or go, which is just abject nonsense that people would think that that's doable or fair. The nature of the workforce is well known. It's 70% of personal care workers who have a level 3 certificate, which is 6 weeks training. The surveys back in 2016, 2017 reported shortages of nurses and nurses feeling that they didn't have the skill set needed. That this was minimum 3 years ago. It's not that none of this is a revelation. None of it requires anyone particularly bright to sit down and work it out. It's laid out and it's there. It really just required the will to pull it together. And if people didn't have the will to pull it together, to at least have gone and asked the aged care doctors and particularly the nurses and the managers, what and how would they manage this type of situation? The heart and soul of aged care sits with the workers and the nurses. They're there. The failures are at a senior level. It's in the coaches and the administration. If you want to use a footballing analogy, it's the board, it is the commission that is running things and oversighting it, that is not helping the nurses and the personal care workers to do the job that they really want to do.
Joe Ibrahim is with you this morning. He's the head of the Health Law and Ageing Research Unit at the Department of Forensic Medicine at Monash University, and is a key expert when it comes to the aged care system in Australia. And he's been worried about the potential for pandemic in our aged care setting for quite some time. What do they have to do now? Either the state authorities, the federal authorities, I don't think anyone really cares now who does it. We've got this new unit set up, the newly formed Victorian Aged Care Response Centre, which frankly sounds like the kind of emergency response centre that you'd get in place before you had infections. But anyway, what should they be doing, Joseph?
Well, I think the positive moves are we've got an emergency coordinating centre. That really now says that there has to be, and I'm hoping behind the scenes, there's actually one person in charge, and that one person can make decisions that are acted on, and it's not really a dress-up where people are bickering behind the scenes and then saying that they're united. We have the commitment from Daniel Andrews, which I think is important and essential to do that. We need a similar commitment from the federal government about what they're going to do now. My worry is that we will deal with this crisis because it's a train wreck in front of us, and we know what to do when we're faced with a train wreck. We provide the immediate care that's required. My fear is twofold. One, we forget how we got to this train wreck, and once the train wreck is over, we don't investigate and look into it. And I'd be encouraging families who are caught up in this situation to be considering their options, and it's very hard to do that when you're bereaved and facing really difficult situations, but there are options. They can ask for the coroner to investigate a death if they believe that care has been suboptimal.
The coroner doesn't have oversight over COVID-19 deaths, but I guess there are other elements you can bring into this, such as neglect in the centre and the like.
Well, certainly. So if it's possible, if there have been issues of neglect, if there have been issues of substandard care that has led to the death, then the coroner may well have jurisdiction to do that. It's an avenue that should be explored. explored.
Where else could you go and complain and perhaps make a bit of noise about this?
Well, I think that the other place to go complain, I think, would be the consumer groups, especially now, given that if we're living in a free market and this is what the law says, then I think families and their loved ones should take up their consumer rights and say, I did not sign up to be living in a home that has COVID-19. I did not sign up to not get the care that I was meant to get. Are you going to refund me the money? How are you going to compensate me for this? I think the other point I need to make, Virginia, is the Royal Commission has been asked to look into COVID-19. The disappointing thing about the Royal Commission being asked to do that is they haven't been asked to investigate what's gone wrong. They've simply been asked to determine how to do things better next time. And I struggle to understand how we will know what to do better next time when we haven't dug deeply into understanding what the problem actually is.
Understanding the history so you don't go on to repeat it again. Joseph, I could talk to you about this all day. It's been really fascinating. I've got a full board of calls because of what you said. I've got pages and pages of texts with people thanking you for what you're saying. So thanks for joining us today, and no doubt we'll get to talk again about this. Take care.
Thank you, Virginia.
Professor Joe Ibrahim there from Monash University. And Facebook, great to have you on board this morning. I hope you enjoyed that conversation and learned something as well. The most important takeout, I think, is that we have known so many of the problems, the pre-existing problems within aged care, that if any kind of emergency like this was going to come along, would immediately make those places vulnerable. And not learning from that, you can hear the frustration in Joe Ibrahim's voice, is the most maddening thing of all. Great to have you on board Facebook. We'll let you know when we're streaming live again.